I just wanted to take this opportunity to welcome all of you who have made it, and for the rest of people that are joining us. My name is Samia Abdi, and I'm a Senior Program Specialist with Public Health Ontario, particularly working on the area of health equity. It is my honor to recognize and acknowledge the land that I'm on. I am on Toronto Toronto, the land of the Wendat people, the Anishinaabe Nation, the Haudenosaunee, the Confederacy, the Mississaugas of the New Credit, and Métis people. Also, I recognize that Indigenous people from across Turtle Island are here today. It's important for us to know that Indigenous people lived here before colonization, continue to live here and up on this land. We also acknowledge the rich Indigenous governance, knowledge production, spiritual, health and wellness practices that existed in the past, still exist today, and that are going to go on into the future. As we are joining, as this is a provincial webinar, and we know that people are joining us from across the province, I would like to invite you all to take a minute to recognize whose land you're on. So if you can do that on the chat box, that would be great. And B, to also understand what is your relationship to the land. And if you are a non-Indigenous person, then I would like you to also to think through how do you benefit from colonization. So as we do that, I believe the chat box is open. So invite people to write in where they're joining us today. We have a quick disclosure that none of us have received commercial gains, and we're not benefiting from this in any way. We also like to declare that there's none of the presenters today have any conflict of interest. Next slide, Caroline. So this is just a quick disclaimer. Next slide. So we wanted to start off with a quick poll, just asking where are you joining us from today? So based on the title of the webinar, we're talking about sociodemographic data collection at vaccine sites. So we just want to know what's the percentage of folks here are collecting. So SVU sites collecting, yes, no, not yet planning to do so. No, there's no plans, or other. And if there's other, please indicate that in the chat box. Thank you. It's really exciting to see that actually 45% of those with us today are actually collecting, and 18% are others are planning to collect. And for those who are collecting in the near futures or do not have plans yet, we will have an opportunity to kind of explore potentially some of the concerns or barriers, and hope that today's session will be helping you decide to collect. Next. So today's webinar objectives are very simple. We wanted to, share and provide a lot of wonderful information from our ministry partners, as well as an updated consent form that they will be sharing. The second piece is to highlight the experiences, the challenges and opportunities from those who are on the ground vaccinating folks, and just have an opportunity to discuss what are innovative ways that data collection has unfolded over the past few months. And finally, to really share some emerging practices as well as resources around vaccine data collection. Next. So this is just a quick overview of the agenda. We're setting the context. We'll have amazing, exciting presentations. We'll have an interactive discussion. And we're really grateful for all of you who've submitted questions. We've taken it in both developing the presentation as well as providing some of your questions directly to the panels today, but also throughout the webinar. Please feel free to message us on the chat. There's also a Q&A button that you can submit your questions. But we also have team members monitoring the chat if you want to share some of your experiences and all of that. Next. So the why is this important? Why are we doing this work? Why are we, we've been pushing for it. Next. So we know that, so this is the model. We know that data collection has to be grounded in understanding of historical context and the current realities, particularly for Indigenous, Black, and racialized people. We know that data collection and evaluation work has been done in really harmful and stigmatizing ways in the past. So we want to make sure that is not a continued practice. There is also data collection can be used as a public accountability factor where communities are involved in all the core components and throughout the steps of from data collection to identifying and improving and as well as evaluation. More specifically, we wanted to make sure that data is stored and used in responsible ways and not in ways that perpetuate harm and decenter communities, rather in a way to really, address health inequities. And that final point is quite critical because data can be collected for an intellectual theoretical exercise as opposed to data for action. So some of the work that public health has been doing, whether it was the data collection for COVID positive cases or currently for the vaccine rollout, it is an opportunity to use data for program planning. It's an opportunity to use this data for redistribution of resources, for refocusing vaccine clinics and vaccine rollout based on particular needs that emerge based on the sociodemographic data that is being collected. Next. So we also wanted to kind of ground today's conversation with this framework that is based on ethics, equity, feasibility, and accessibility. When we think through ethics, we're including factors such as individual and communities, respect for individuals and communities, minimizing risk, naming justice, centering trust and trust building, creating accountability, inclusivity, responsiveness, and transparency as ethical principles. This framework also centers equity in a way that, for example, uses an equity metrics to identify potential and distinct inequities that may raise based on the vaccine rollout. We're talking about inequities that are based on pre-existing conditions such as comorbidities, inequities that are based on place of residence, race, ethnicity, immigration status, occupation, gender, sex, religion, income, and other social determinants of health. When we think about feasibility for vaccine rollout and vaccine administration, we're thinking about factors like availability of resources such as the vaccine supply. We're thinking about funding for certain, community-based initiatives. We're thinking about ways to integrate vaccine delivery into existing programs. And finally, the final bubble here is around acceptability, so acceptance of the vaccines. And then we're thinking particularly around questions around safety, again, trust, availability of information, places to get vaccinated, processes for vaccine, whether it's booking of the vaccine or actually receiving the vaccine. We know over the past few months, there has been a lot of communication, a lot of conversation about vaccine hesitancy, particularly for Indigenous, Black, and other racialized communities. And we know all of the myths that were previously believed in around vaccine hesitancy has been debunked. And the conversation has shifted largely due to a lot of the work that folks who center equity in their work in public health and in other fields in the healthcare system have been leading around changing the conversation from vaccine hesitancy to vaccine uptake and focusing on removal of barriers. And once the social demographic and socioeconomic barriers have been removed, then we have seen a surge of uptake for vaccines from marginalized communities particularly. Next. So what we know so far. So this is actually a very, unpublished yet, but will recently be published Ontario Public Health report that is showcasing the trend of vaccine administration over the past few months, and we can clearly see a change in vaccine equity, for example, from the early onset of vaccine administration starting in January and where we are in May, and particularly noticing that those folks who live in quantiles with higher neighborhood diversity had a less of uptake throughout the month of March, and that has drastically changed during May. Equally, if we look at the next figure, which is around neighborhood material deprivation, again, we see that the neighborhoods that have a higher material deprivation also had and continue to actually have lower percentage of first dose of vaccine. It's very important as we look at these numbers and we look at this data to understand the cumulative impact of systemic racism, structural barriers that have an effect on uptake of vaccine, particularly amongst Black, Indigenous, and other racialized communities. And although we know that there has been inroads made around vaccine uptake in the marginalized communities over the past month or so, we know that because of all of the amazing work that has been done at neighborhood levels through community-led, culturally safe, accessible vaccine clinics, we know that the road to equity is still very long. And more importantly, we need to also acknowledge that this is using neighborhood level data, which is an important step in understanding the overall picture of COVID vaccine uptake. However, using this level of data limits the ability for detailed tracking and examining interventions and also interpreting these results, not taking into consideration the nuances that exist within neighborhoods and within communities. Therefore, access to individual level demographic data is critical because it will be able to allow us to do more powerful data analysis and to use interventions that strengthen planning at the public health level, community health level, community health center level, and all of the folks who are involved in this work of vaccine delivery, as well as provide us system level, healthcare system level analysis and action. Next. So I think we went through this poll. If we can go through just the next poll. So if we can have, Lydia, if you can put up the next two polls that we had. Okay, so this is a useful, so I think what we did is actually we sent these like quite late into the prep work, and they landed up in the first ones, a few ones. So for those of you who are, actually for everybody, whether you are on a site that is collecting, not collecting yet, thinking through collecting, what are some of the barriers that you're finding implementing this work? This is going to be helpful for us regardless for our own evaluation work, as well as the rest of the presenters as they presented their experiences and their data. So please go ahead and fill that. So workflow seems to be like when, who, how seems to be a huge barrier that folks have highlighted, as well as data entry issues or patient hesitancy has been also highlighted as perhaps one of them, but also staff preparedness. Thank you. Next slide. So I would love to welcome our partner and co-developer of this work, Yolande Davison, Director of Indigenous French Language and Priority Population Branch, as well as Strategic Policy Planning and French Language Service Division. Welcome, Yolande.
Thank you, Samia, and thank you to all of our partners at Public Health Ontario for joining together once again to put on. This is our second webinar with respect to sociodemographic data collection. I also want to thank my team who are here on the line for the work that we've been doing since we launched the data collection on March 5th to be in touch with vaccinators to continue to learn about experiences, and we're going to be able to hear about some of those experiences during this conversation. So I'm really excited about that, and I'm also grateful to see some of the responses coming in on the polls, and hopefully some of what we are going to discuss today will help to provide some insight to some of the issues that are raised. Next slide, please. So I'm not going to belabor the purpose too much. I think we all know why we are here and having this conversation. In particular, I think the goal for my team at the Ministry of Health is to be able to provide some updates on what we have been hearing from vaccinators and vaccination sites, as well as provide some updates on what's been happening since March 5th and some resources that we would like to share that hopefully address some of the concerns that are being raised. Next slide, please. Again, I won't belabor the key context too much. Samia did a great job of taking us through what the key equity considerations are and why this data is important and why the ministry implemented this data collection in the first place to be able to understand who's being vaccinated in the province and in order to inform vaccine rollout and to ensure that those who are facing barriers, who are disproportionately impacted, and in particular, Indigenous, Black, and racialized communities, people facing low income and other barriers, that they have equitable access to the vaccine. So I'm not going to delve too much further into that, but that's really the goal of what we're doing here today. So in terms of the current status, as I mentioned, we've been maintaining pretty consistent contact with some vaccination sites since March 5th. And so I guess we're entering almost June at this point and really in the close of our third month of data collection. And we've been obviously monitoring the data collection uptake over that period of time. The data collection has been steadily increasing, but it's by far not where we need it to be. I would say that there are a small number of public health units across the province who are doing the vast majority of the collection. I saw in the poll results that came up earlier some concerns around perhaps people not wanting to or not being comfortable answering the questions. And that's been a reality. And we have some tools that we will share with you today and after the webinar that hopefully can address some of that. But we've been quite heartened to see actually that with the data that has been collected, the collection rate or the acceptance rate for consent is actually quite high. It's over 90% consistently and sometimes hovering around 98%. So the vast majority of people who are asked these questions are actually answering them, as you see there on the slide. That said, we do recognize that persons are not being asked for a lot of the reasons that came up in the poll, and these are the same reasons and feedback that we've received as a team from the vaccinators that we're in touch with. Privacy is already, I've mentioned. Clinic flow and time has been a big one, and some others that I'll get into in the next slide and share again some opportunities to hopefully ameliorate some of those concerns. Next slide, please. So specifically, we've heard a range of things, but these are the three biggest areas of feedback I would say that we've received over the course of time that we've been talking to vaccination sites. Concerns around timing. So I would give a bit of context on the consent language in the form. For those of you who are collecting, you know that this information is captured in the COVAX system. There's also a paper-based version of the consent form, just like there is for the actual vaccination consent form itself. And the consent form language on that paper form mirrors exactly what is in the COVAX system. And similarly, with the way that consent is taken for the vaccination itself, this tends to be a verbal interaction between the person coming for vaccination and the vaccinator, where consent is received through a conversation or through a verbal interaction. So those are some of the consistent elements across the consent process overall. And what we heard around that is that timing was a challenge. Getting through the key pieces on that consent form took longer than many sites felt they had time to offer. And there are a number of reasons, I suppose, why the consent form sort of got to the length that it did. As mentioned earlier in Samia's presentation, we're very mindful that this data collection is important, but the safety of this data and the trust and the process of building trust around this data collection is equally important. And so while we were in the planning phases and preparing to do this launch, we spoke to a range of folks, some of whom are on the line and you'll be hearing from today later on about their vaccination experiences, but we spoke to a range of folks across different parts of the health sector, providing different perspectives and aspects of the process that we need to think about, and governance was a really big one. And so the consent form initially was meant to reflect a lot of the governance considerations that we thought people would want to know about in terms of what the data is being used for, how it's being controlled and accessed. But of course, that results in something that's not necessarily as easy to use or implement in real life situations. So we've taken that feedback, and as of Wednesday, this past Wednesday, the 26th of May, the consent form was relaunched or released again with much shorter language that still captures some of those key elements. So I'll get into that a little bit more when we get into some of the other feedback that was offered around timing. We've heard about space in terms of privacy, and that there isn't room for much privacy in the interactions, and particularly because this is sensitive information, that there may be discomfort with asking or providing on the part of the vaccinator or the individual. And we also heard about collection through the pre-registration system and the opportunity to collect there. Next slide, please. Next, thank you so much. So I've already gone through some of where we landed with the work to address the feedback on timing. The consent form and consequently the language in COVAX has been shortened significantly, still holding on to some of those key details around privacy, around what the information is for, why we're doing this, but making it more usable in an in-person interaction. And we're really mindful of the data collection or the capture burden when reporting on this. And so we've taken that feedback, are focused on continuously trying to improve this process based on what we're hearing. And that's one of the things that was launched this week in COVAX as well as online. I do want to reiterate also that one of the things we've heard from public health units who are, that are collecting is the paper form is available. Most aren't using it, and of course we try to not be paper-based unless necessary for environmental reasons, but it's there as a resource or a tool as well. Some sites have posted the paper form in their clinics. If there are barriers between the client and the individual, sometimes the form is posted. When people are waiting in line to go up and do their registration or intake, the form is posted so that they can see it and read it and become familiar with the content. So I would also encourage everyone on the line to think about what potential opportunities there are with the form itself, particularly now that it has been shortened and the language is more plain. In terms of privacy concerns, we heard a range of different approaches that vaccination sites are taking. One of those in particular that we will be providing a resource for is a client answer guide, is what we're kind of calling it. This was greatly informed by some of the work that Ottawa Public Health Unit has shared with us on what they are doing. And essentially, it's a form that takes the information that is asked from the consent in COVAX or on the paper form and puts it in a format on a one-pager, French or English, that an individual could potentially point to if that's an easier way to answer it in a format that's visually accessible and allows an individual to select or indicate their answer without actually verbalizing it if privacy is a consideration. So may not be appropriate for everybody, but we hope that that's a tool and a learning that we've heard about that can potentially benefit others, depending on your capacity and your clinic flow. In terms of pre-registration, this is feedback that we get a lot. And I will reiterate, as I mentioned in the last webinar, that the opportunity to put this into the pre-registration system is a core part of the approach of what we are doing. It's not something that's been an afterthought or not considered. It's something that we have been actively working on with our IT partners in the ministry for some time. There are some technical considerations around making that happen. But we are getting closer to the point where we will be able to have this data collection happen through the pre-registration portal, the provincial pre-registration portal, so that individuals who are booking appointments, even for second doses, will be able to, in the coming weeks, provide this data themselves, which hopefully will eliminate some of the reporting burden. But that's always been a key element of what we have planned to do here. Hopefully we'll see that come in soon. I see some questions coming up in the chat, and I'll take them one by one as I get through the slide. So thank you very much. Next slide, please. So I mentioned what some of the resources are already. We have a tip sheet that provides a summary of some of the approaches that we've heard about from various vaccination sites in terms of how people are using the consent form, how different sites are seeking consent and answers to the questions other than through verbal interactions and using different types of tools. We have, which is the client answer guide. There's a client information sheet, which we will be sending out afterwards, which provides some of the same information that is on the ministry website in a client question and answer format. So again, something that could potentially be posted in a clinic where an individual could read a little bit more about why this data collection is happening and understand what some of the rationale is and why the data is important. Next slide, please. So in terms of our next steps, we're going to continue speaking with vaccinators about this and how it is progressing. It's critical. We have a huge opportunity with second dose, especially considering that timelines are advancing. It seems like every day we get a new update, which is very encouraging in terms of moving towards full vaccination. But we're still mindful that populations who have always faced different types of barriers, systemic and otherwise, and again, particularly Indigenous, Black, and racialized communities, still need to be thought through and considered as priority populations for this type of data collection, so that public health units in the province can be aware of how different communities who face different levels of risk are being reached. So we're going to continue speaking to the public health units who've been really helpful in engaging with us and with other vaccinator communities as well, including pharmacists who we've also engaged with through their regulatory college. We've also spoken to and heard from many community vaccination settings in terms of folks who are targeting through mobile clinics, very specific populations, for instance, mobile clinics happening for people who are not securely housed or are facing homelessness. So we're continuing that work and thinking through all the time how we can work to improve the process, and in particular, if there are technical solutions even outside of the booking system that we can look to. There are a number of things that I would love to be able to come to the table and say, here's something we could do or not do. But of course, we're working through many challenges and pressures as we try to respond to all of the priorities around the pandemic. So the appendix contains some screenshots of what the data capture looks like in COVAX. I won't go through those, but essentially this data capture, this section, is in the same area of COVAX where the mainstream vaccination consent actually occurs. So once somebody's been asked for their administrative data, their name, their address, their gender, all of these things, this information is the next piece that follows, and should be able to be easily accessed by vaccinators who are collecting or who wish to collect. These slides are going to be shared with the group afterwards. I see some things happening in the chat. Sammy, I don't want to disrupt the flow here. Is it appropriate for me to answer some of these questions really quickly?
Yeah, you can. Go ahead.
Okay. So I see what PHUs are collecting the data. We've had There are very few PHUs that are not collecting at all. The issue is there is not consistent, sustained collection across all public health units. I can tell you that the 4 public health units that are doing the majority of the collection, and the vast majority, meaning over 90% of the collection, are Hamilton, Toronto, Ottawa, and Kingston, Frontenac, Lennox, and Addington Public Health. When it comes to other public health units, the collection is very variable. And we definitely have seen where we have seen upticks, I guess you could say, in terms of collection at different points in time has really been when community-based approaches are taken and community vaccination clinics are taking place to reach out to and particularly be intentional about collecting this data from specific populations that they're targeting. Thank you, Ashley. I see you in the chat. Hamilton is definitely doing the same thing with the consent client answer guide to help facilitate easier answers. There's a question around the point of vaccination sociodemographic data collection. That's a great question.
So Yolanda, I think maybe the other presentations might have an opportunity to answer some of those questions. So
can I just answer 2 more because I think they're relevant specifically to the ministry's work, and then okay. So COVAX was the way that this was implemented in the COVAX system is that clinics can collect this data at any point in your clinic flow. So there is no sequence in COVAX that you're being forced into. If it makes more sense for you to collect it at check-in versus observation, it really depends on what works for the structure or the flow that you've determined. And we're going to hear from, as Samia just signaled, hear from some of the vaccinators who are on the line today about how they've chosen to implement it and at what point in the flow. But that is not a decision that the province is making through COVAX. The client answer guide could be translated into other languages. I will also add with the form itself, that is going to be translated into the 20 most used languages in the province. We're just waiting for some final accessibility stuff to be done, and that will be posted on the website so that that's available for folks to use. So I will stop there because I think I've probably talked too long and turn it back over to Samia.
Amazing. Thank you so much, Yolanda. That was really informative. And I know that you've mentioned a number of resources that are coming along. So we just want to let people know that these will be sent along with the evaluation. And also for our other presenters, if you do have resources or tip sheets that you want us to send along with as a package to the participant, please do let us know and we'll be happy to do that. I would like to welcome our next guest, Laurie Dojiji and William Rowan from Ottawa Public Health, and just to share some of their experiences as folks who've been doing some really innovative and interesting way around ensuring vaccine equity and as well as collecting this social demographic data. Thank you. Welcome.
Thank you. Thanks so much, Samia, for that kind introduction, and Yolande for setting the context for us. Obviously happy to be here with my colleague Will Rowan to share what we're learning in terms of our journey in collecting this important information. And I would say that an important piece of context, at least for OPH, Ottawa Public Health, is that we had been on a journey in terms of seeking to collect standardized sociodemographic data prior to COVID. We had been on a path in terms of trying to build it into our new electronic public health record. So I would say that having this foundation to build on, having the support of leadership and a shared understanding within the organization of the value of this information did position us to be able to pursue collection in the context of COVID. So did want to sort of lay that foundation as an important building block for us. In terms of what we've been doing in the vaccination clinic context, we actually started by piloting with one of our local hospitals, with the Ottawa Hospital, in mid-January to explore different processes, approaches for gathering this information. We really just wanted to try and see where in the clinic flow it might be most feasible to gather this information. So we tried 3 different approaches. The first was using a paper form in the early registration phase, so right when they are on site and doing their registration and consent. The second was using that same paper form, but introducing it in the recovery area. And the third option was creating a flyer that had a URL and a QR code so that clients in recovery could complete the survey online, so removing the paper. So that taught us a lot. I think what revealed, in fact, was that the paper collection in recovery was the most successful. We probably had about 50% participation, but the downside was that the paper forms were anonymous, so they were not linked to clients. It's a lot of work at the clinic level to collect, store that paper. It then would have to be looked at or back entered into another database to analyze. And also IPAC considerations if you think about pens and clipboards. So ultimately, while paper proved more successful, our goal was to go paperless and to be able to ultimately have it linked to clients. So when the SDD questions were introduced into COVAX, OPH in mid-March started to trial the collection of SDD at some of our select pop-up clinics. So while we favored the recovery and checkout, we actually decided to trial it at check-in. And the reason for that is because checkout relative to check-in actually had less capacity. It was actually less space, and those privacy considerations seemed to be more of a challenge at the checkout than check-in. And the other was that the clinic teams were really striving to try to do all of the data collection up front so that there's minimal steps needed for the clients when they are discharging from the clinic. So those were some of the reasons why we have been attempting to collect at check-in. So with that, I'll turn it over to Will so that he can share some of what the on the ground experience has been like, what we've experienced in terms of some of the challenges Yolande has already spoken to, but what we've also tried to do to combat some of that. So over to you, Will.
Thank you. Thanks, Laurie. Yeah, so to go over again, just to sort of reiterate some of the successes and challenges that we encountered, and me being a supervisor for the clerical staff that are doing the data entry and sort of seeing it firsthand and sort of trying to troubleshoot some of the issues that occurred. Again, as mentioned, we were primarily doing the collection of the data at check-in, and the amount of time that was dedicated or needed to fully address the collection of this data was about 40% of the total time spent at check-in. The general rule that we were given to our staff is that if a backlog is created because of this extra time needed, then it's deferred, and then we sort of wait until we reach another point where the clinic flow has evened out and is steady again or quiet, and then to reattempt to collect again. As of the May 26th changes that have been recently updated to COVAX, we do feel that the SDD section changes that were made are helpful. However, there's still some functionality and other issues that we are still identifying as issues that still cause quite a significant amount of time that's spent collecting the data. Some clients also are taken aback when we're asking them these questions, and they sort of, there's a lot of time having to sort of explain to them why we're collecting them and the value of it, despite the fact that we have also sort of created large posters that sort of explain exactly, why it's important, why we need it, why we're collecting it, not that we're collecting it to, give it to anyone who shouldn't have it. But there's still a sort of lack of trust there, and even more time is even spent on not even just asking the SDD questions, but actually explaining why we need the data and why we're wanting to collect it in the first place. In addition to this, again, as mentioned, clients not knowing like where the data is being used, who has access to it, who can also see this information. Again, more time spent explaining these sorts of things to people when they ask it. In addition, there was also the mention of language barriers as well. As public health, we've only been offering these in English and French. We haven't had the ability to sort of do full-scale translations in the same way for all the other languages, which there are many of here in Ottawa as well. So for now, it's only been in English or French, which creates language barriers as well. The biggest challenge overall, if we had to sort of, again, pick what the biggest challenge would be, again, as mentioned in the poll, the impact that it has on the workflow. But also, this is mostly due to the fact that in mass clinics, the noise level and lack of privacy sort of connect as to why it's so time consuming in this case. Clients have to sometimes shout their responses if they don't want to use the paper that we provided, as mentioned as well. If they are comfortable using the laminated copies and pointing to the answer, that is the preferred method of collection that we have. But at times there's others who, based on various circumstances, may either need to actually say their responses out loud, which then creates privacy issues and, time on behalf of the clerks having to clarify their responses to make sure that they have the appropriate response. To counter some of these barriers, we have created and utilized some of the support tools that are available as of now. One being the ministry provided job aid, which helps the data staff know what they're doing and know how to ask them in a comfortable manner and in the best way possible. Again, as mentioned, the poster, which we sort of blew up to be, quite a large poster size, that sort of explains the reasons for collection and whatnot. Again, we do think it is helping, but a lot of people are there just to get their vaccine and leave, right? They're not going to spend time looking at this giant poster board explaining why we're collecting this data. So it has been helpful to some degree, we believe, but there are those individuals that just have no interest whatsoever. And then, as mentioned as well, the laminated sheets, and laminated being to cover any IPAC concerns as well, so that they can be wiped down after each individual may have touched them to answer their questions, such that there's no issues with the numerous people touching them over and over again. It's wiped down each time. In addition, the clinic teams have also tried to have at least one dedicated individual collecting the data at mass clinics. And again, this was sort of an evaluatory type thing to sort of see how the impact of flow is with just one dedicated person doing it. And then as the sort of flow changes over time, we get peaks and valleys. The leads at the clinic for the data staff attempt to try and have more clerks doing it, as evaluating on flow. And then if the flow is too constant, or it's too busy, or it's creating because they've added too many clerks, then it gets scaled back or saved for evenings, when evenings are typically a little quieter compared to the rest of the day. Again, only speaking for mass clinic settings specifically. And to touch on the community clinics as well, we believe that the reason why the collection is so much better at these more smaller scale clinics is because of the fact that they are smaller scale. So the flow is much different compared to the mass immunization clinics, which are much more voluminous and much more steady in the amount of patients or clients that come through when they are getting their immunization. And finally, the methods of collection as outlined, despite being the most efficient model for us at Ottawa Public Health, we also feel that it's definitely not the most efficient way. And again, sort of echo previously that, doing stuff in a manner that's more private and one-on-one, such as at booking or something like that, would be much more effective compared to such an open public forum. And then Laurie, just with a quick wrap up as well.
No, just to say, I mean, we don't need to be convinced on the value of this information. We want to gather it. We know it's important. We're with applying best efforts to do so. Would really, look forward to learning from others, and appreciating the support that PHO and the ministry are providing to enable this. But do have some ongoing concerns about the completeness and the reliability of the data going forward. But again, look forward to learning and continuing to improve our processes as a collective. So thanks for your time.
Thank you, Laurie and Will. So I would like to, and for sharing with us the Ottawa experience, and particularly the Ottawa Public Health experience. Next slide. I would like to welcome Angela Robertson and Cheryl Prescott, who have been doing such incredible work in Toronto. They are both heroes in this part of the province. So welcome to both of you, and please share with us your experiences from community-led and a community health center's perspective. Thank you.
Thank you so much. I'm Cheryl, and I also wanted to add that Michelle Weston will also be sharing a few words, because Michelle is very instrumental being on the ground with the logistics of the clinics, and she's also a senior analyst at our CHC who is a champion for data collection. So really an important part of the process. So on the next slide, I think, yes, just who we are, Black Creek, great collaborations between CHCs in Toronto, even though we're geographically separate. This slide really just is a pictorial representation of the diversity of the clinics and who we actually serve. It's really important to note that I think the success of our data collection efforts is due to the involvement and empowerment of community ambassadors. So regardless of the clinics that we're doing, whether it's in an apartment building or a large community center setting, or in a church with different groups of folks, such as we just recently did in the past week, a clinic with a Vietnamese population where we engage with the Vietnamese Association. Yesterday, we did a clinic with the Latin American community, where we engage again with the community to help us along each step of the way of the clinic. So from registration to through their journey throughout being vaccinated, as well as data collection, the socio-demographic data collection. So again, I just wanted to reinforce that this is a community where, with very high hesitancy, vaccine hesitancy, that was really translated to uptake because there was now access to vaccines. I think Samia mentioned it earlier in her setting the stage, that we work very, very hard to engage so that to work with overcoming the vaccine hesitancy. But when vaccine supply was made available to the community, we really saw a big uptake. And throughout, with all the clinics that we've done, all the models we've utilized, social demographic data collection was done from early on with just a few patients or clients to thousands of folks being vaccinated. And we are so we know the importance of data collection, but we also know the importance of data safety and information safety and privacy amongst a community that has a high level of distrust of our systems. So I think in the next slide, we just wanted to illustrate also that the nimbleness and flexibility of collecting this data, but I'd like to pass it on to Michelle, who's on the ground, as I said, and has heard the stories and has witnessed some of the interactions to really showcase how we've been able to adapt and ensure that we got the information that is so vital.
Okay,
Michelle,
great, thank you. Great, thank you, Cheryl. I would really want to, I think, reiterate, as Cheryl had mentioned before, and our previous presenters, how important it is to build the data collection into the workflow and ensure that the people that are on the ground doing the clinics, no matter what part of the team they are, understand the importance of including it as part of the overall process. So we really view that the collection of sociodemographic piece just as important as the registration, just as important as the aftercare, just important as the observation. So one of the things that we do as part of our clinic is we always do an initial huddle. So that's a huddle with the entire team. And part of that huddle is to talk about logistics, but also to remind everyone that this collection of sociodemographic data is part of the process and that it will be done, and it will be done during observation. And these are the key messaging that we will be sharing with our community members to do that. So we really have it well integrated into our process. To Cheryl's point also, working with community ambassadors who are also working through the line. They are members of the community, they are trusted messengers. So really the first face that community residents see when they come to a clinic is a community face. So they are there to talk about the process of the clinic, answer any questions that people might have, and start really that trust building and trusting, engaging piece, and letting people know again what the process of the clinic will be like, and letting them know that we will be asking some questions in observation, and this is why we're doing it. So we really view our vaccine clinics as part of community engagement, and that dialogue is ongoing throughout the process. Just with other people, they mentioned in the presentation, we've done mass clinics as well as internal clinics at the center. We do the sociodemographic collection at our larger clinics during observation, just similar to other organizations have done as well. And I think, part of our success is, having, the folks on the ground, whether it's the documenter or the ambassadors, be a face that they recognize, whether it's from someone who is representative of their community, representative of their cultural ethnic background, speaking the language that they're familiar with, getting down on their knees really, and speaking to people at that level. I've seen amazing interactions happen where there's that empathy and that connectedness between the documenter and the person attending the observation period. And that trust building has really helped in, I think, the success of our data collection. So I think my overall message is you think about ways you can build it into your workflow, but the whole process, it's not just about, what you're asking, but who's asking and how you're asking it as well. And I think that's just been an incredible part of our success. So I'll turn it back to Cheryl and Angela for more.
Angela Robertson here from Parkland Queen West Community Health Center. I think just in ending off on this slide, it's noting that, you know, this is an adaptive and iterative process. So it's a process improvement. And somebody in another meeting said it's a great QI initiative. I think similar to what some others have shared from our partners and colleagues in Ottawa, is we have also done here within our community health center, when we have done small clinics, and small meaning like 100 and or 100 to 200, is at times we have used the paper and we have collected in terms of health identifier on that paper, and then it means then that we do a manual entry after. It is labor intensive. It requires additional human resource in terms of capacity, but that just speaks to the extent of the commitment to try and collect the data wherever possible. So that then speaks to some of the changes and improvements. And I know that Yolanda identified in her presentation earlier some of the improvements that have been made in the consenting process to hasten and improve the flow. And one of the things that I think we continue to ask for is some iterative improvements in the formatting itself of the data collection process in COVAX, so that we have some rapid drop down that can really hasten the ease of the data collection. So really asking for that to be looked at. The next slide. In terms of some of the things that, as part of a broader collaborative, we have a broader collaborative that has been looking at race-based data collection from the moment of COVID, in terms of COVID testing. So we had some initiatives that in terms of the Toronto Public Health Unit started around in terms of that data collection, and then we wanted that to parlay into in terms of vaccination efforts. We feel disappointed that we have not seen the uptake with the community advocacy to get this data included in COVAX. We have continued to be disappointed that there has not been the consistent and widespread uptake with the utilization. So one of the things that we feel that opportunity is not lost, and from a Black Health Plan table that has been convened with Ontario Health, is we are leaning in to push for the mandating and or some more strident directive for collecting sociodemographic data in the dose 2 delivery. And the provincial announcement that just came, there is an opportunity in front of us, we believe, to advance in terms of, and to close that circle on folks who may have been missed in the earlier in terms of collection. We feel that there are some enabling supports that the ministry can offer. So one is, we believe that the Chief Medical Officer can do some promotion of that in some of those daily press briefings and huddles to promote the importance of it to the general community, as well as the Minister of Health. The other piece I think Michelle and others have spoken to around the value of having these interventions in community, because we know the mass vac sites sometimes pose a challenge with the issues of trust. And we've seen significant uptake at the local. So as much as possible, where there are opportunities to bring vaccine efforts to the local is important. The other piece that we feel needs to be a constant echo is the issue of provider comfort or provider disquiet, because we have identified and heard and seen that it is sometimes the provider disquiet that at the point at which the movement stops in terms of collecting the data. And therefore, what is it that providers need to enable their comfort in order to ask these questions, twinned with the information about how the data can be used in real time. Samia, I know that when you presented those two slides, and I will just end off, when you presented those two slides or those two graphs that speaks to material deprivation and neighborhood diversity, is we feel that that is a a good global picture, but what it doesn't enable is the more nuanced population targeted community strategy that can be enabled when we have this data in front of us, so that we can make real-time and long-term changes to strategy, so that we can rapidly identify who are the populations who are not being immunized, who we know are differentially impacted. So I will just end there because I think the other comments speak for themselves in terms of broader system strategy around the value and the importance of sociodemographic data collection to close the equity gap and to respond to sites of inequality. Thank you.
Thank you, Cheryl, Angela, and Michelle for that excellent presentation. We know that we are approaching time very quickly, but also know that we've packed in as much goodness as possible in this 1-hour webinar with folks like Yolande, Laurie, Will, Cheryl, Angela, Michelle, who can just hold up space, you know, on their own and speak to their very different and important and critical experiences for an hour. So perhaps there might be future opportunities for collaboration and engagement that we might be able to create. As everybody has mentioned, that this is just the wheels are starting to turn, so there's a lot of more work ahead of us in terms of this data, not only at a collection level, but analysis, use, and interpretation in safe, equitable, culturally safe methods. So I think we've been, maybe Pam, if you, I don't know if you've highlighted 1 or 2 questions for the panelists that we might be able to take up.
It's been great because the panelists have been entering responses to the questions as we go. I think maybe one that I didn't see an answer to is just again with the flow, whether it's reasonable to hand someone the tablet to fill in themselves, like just in terms of the practicality. And I know that, yeah, Yolande and the speakers from Ottawa have been able to answer here. So I think if there's any other general questions, or if you wanted to go back to the previous slide afterwards to address some broader issues. But I wondered for any of the speakers if you had a comment on the tablet question.
We haven't handed off the tablet for inputting. You then get into your iPack, and then you also get into the scrolling features. Not everybody is proficient in that. So those would be some of the challenges. And depending on your population, people are also, the assumption of literacy is also an issue where folks, if they're just being handed off the tablet, may say no to collecting, not because they don't want to, but because they also don't want to disclose language and literacy issues. So those would be just some of my early consideration about why that might be seemingly expedient, but may also bring up some other barriers that you may not immediately hear.
And maybe there's one last question that, and whoever, either the Ottawa folks or Angela, Cheryl, and Michelle can take this up. And the question that was submitted actually prior to, as a part of the registration form, is what are some analysis plans for this data in terms of how it's going to be used, as well as reporting back to communities.
So I would turn to Yolande for that, in terms of, I can tell you some of the things that we are certainly interested in. Is we're interested in the ability to get some real-time analysis. So after we say do a cycle of immunization in a particular hotspot FSA, is that we can do a real-time analysis to see what is the demographic scan of who has been immunized, because then we can develop an immediate strategy to reach populations that have not been, in terms of, that has not shown up in the immunization line. So that allows for real-time planning. And then longer term, it can certainly then speak to some of the longer term planning and strategy, but I'll turn to Michelle as well.
Yeah, I agree. I think also one of the things that it's important to consider is there is a level of accountability that happens with organizations, especially the community-based organizations such as ours that are leading these vaccine clinics. So again, many of the populations we're working with are populations that do have mistrust. Often they are over-surveyed and over-researched in many ways. And one of the biggest questions is, you're collecting this information from me. How are you going to use it, and how am I going to see that data? It's that data ownership piece. So I think as an organization, when it's Black Creek or we're going out and saying, like, please come to our clinic, and then we're asking questions, and then we don't do anything with that data, that just unfortunately, can lead to broader mistrust as well. So I would like to see, not only the use of the data for planning purposes, but also sharing back with community so that they can see themselves reflected in this process as well.
Thanks for those comments, Angela and Michelle, and for the question. The first thing I would say, and the core objective, going back to why this was started once again, is exactly for the purposes that have been mentioned in terms of being able to inform not just the province's activities, but vaccinators' activities in general in terms of reaching people who want to be vaccinated. The first thing I would say is a challenge for us, I'll be honest, is the data quality in terms of the uptake that's happening and needing that to be improved. We're working internally to figure out how we do appropriate reporting on what we have. And so it's not that we're purposely withholding the data at this point, but we're also really mindful of not being in a position where we're releasing data that can create potential harm, because that's one of the core pillars of what we're doing around our governance. And we're mindful of some of the narratives that can be potentially created once that data gets out there. So there's a twin piece here happening between the relationship of the data collection and actually doing that data collection. And then the uptake. So I hear a lot of public health units asking me for the data, and my question is always, are you collecting the data? I'm going to be honest, right? So maybe I would have more to give you if there was collection that is happening. Like, I have to be very frank about that. So that's a dual reality that we're facing. But then at the same time, because we have a sort of governance structure that we're really trying to be deliberate about in terms of being really respectful of the use of the data, those are the things we're considering. So we're working on it. It's coming. We're trying to get to a place in a format that is useful so people can access it and use it for the purposes that you need it for, but that also maintains some integrity around what we put out.
Wonderful. Thank you all for really getting into that answer. And, just there's a lot of work ahead of us, but really amazed at the level of engagement and what has been shared today from our incredible and powerful and amazing speakers, as well as I wanted to take a minute to also thank my team members, Pam Lees and Caroline Beneta-Bayesh, who's also done a lot of work in the background, and Lydia, who is managing all of our tech today and doing a lot of amazing work keeping us on track. Thank you all for showing up and showing off all of the amazing work that you're doing. We will continue doing our best to continue engaging our public health units and public health partners, as well as our community health centers and other factions and parts of our overall healthcare system as we go through this pandemic, and continue to center equity as we do this work. So thank you all. You will be receiving an evaluation link along with a number of resources that Yolande has spoken to. And I welcome both Ottawa and Angela, Cheryl, and Michelle. If there is anything that you want us to pass along to the participants, please share it with me, and I will make sure that it goes out to our participants. Thank you, everyone, and happy Friday, and have a wonderful weekend.